I'd like to welcome everyone to tonight's AFS webinar on the evaluation of GERD in the bariatric patient. My name is Ann Wynn. I'm a gastroenterologist at the Center for Esophageal Diseases at Baylor University Medical Center, and I'm going to be your moderator for the evening. Tonight, we're going to go through a series of clinical scenarios, I think, commonly encountered in the bariatric surgery world and hear from our panel of experts on their approach. We will be taking questions from the audience after each case, so please feel free to type your questions in the Q&A section at the bottom. Before we start, I'd like to introduce our panel of gastroenterologists and surgeons. First, we have Lena Caton. She is professor of surgery and division chief of GI and general surgery at University Hospital Cleveland Medical Center. We also have Anthony Starpoli, who is a gastroenterologist in private practice in Manhattan and Hudson Valley, New York. His practice focuses on GERD, obesity, and endotherapy. And then finally, we have Mike Ujiki, who is vice chair and chief of GI and general surgery at Endeavor Health System in Chicago. So let's get started. So our first case is a 54-year-old male. He comes to your bariatric clinic and he's interested in bariatric surgery. He's never had bariatric surgery before. He's been trying to lose weight for several years through lifestyle, dietary modifications without success. His BMI is 38. He also reports heartburn after eating. This has been going on for 20 years. It occurs 4 to 5 times a week. Triggers are if he eats late, eats spicy foods, tomato-based foods. His past medical history is significant for diabetes, hyperlipidemia, obstructive sleep apnea. He has no past medical surgical history. He takes antacids for his reflux every other day. He also is on metformin for diabetes. And in terms of prior endoscopy and imaging, he's never had any of that done. So I guess before I move on to the questions, I guess, is there anything else that you guys as the panelists would want to know about this case?
Yeah, I'd probably ask the patient in terms of his reflux, if he's ever lost significant weight before through, calorie restriction like dieting, did his reflux get better or not? Or has his reflux just been there regardless of his weight?
Yeah, no, that I think that really highlights kind of what changes happens to people's reflux with weight changes. I've had people tell me they've been able to get off their PPIs when they lose weight. So I think that's a great question. In his case, he hasn't lost a huge amount of weight where he noticed a difference in his reflux in the past. But yeah, I think that's a very important history question to ask.
Yeah, there were two things that I would want to know about. One, you said he takes antacids every other day. What happens if he doesn't take them at all? Like what happens to his reflux? Is it something that's unbearable, or if he avoids trigger foods, it's tolerable? So that's one question. The other thing I'd like to know is a little bit more about his type 2 diabetes. How long has he been diabetic? And what's his last hemoglobin A1C?
Yeah, so in terms of his antacids, he does get relief with that. He says that if he doesn't take it, he's pretty miserable without them. He does take them pretty often. I think we've all had patients come into clinic, and it's kind of important to know how much antacids they're taking, right? I have patients that tell me I'm taking antacids like candy, and then others that say they take a couple. So I think quantifying that's important. So he does feel pretty miserable when he doesn't take them. To your second question, Lena, his diabetes, he's had this for 10 years now. His A1C has been around 7 to 8 range. It's never been above that. It's kind of where he hovers throughout it hasn't had great changes between that range.
And is his diabetes managed by his PCP, or does he see an endocrinologist?
He sees a PCP. He's just on metformin. He's always been on metformin for his diabetes. I guess.
Any history of early satiety?
No, he doesn't have any early satiety or any bloating or fullness after eating, on ROS anyway.
And also, is there any history of regurgitation?
So he doesn't endorse regurgitation of either acid or food. His main symptom in terms of reflux symptoms is mainly just burning in his chest.
And has there been a PPI trial?
That's a good question. He says that he's been on antacids. I think he hasn't been on PPI. And I think this is something I think we all commonly see as well, is like a lot of patients, in some ways, society normalizes reflux. So people don't always talk about it with their, PCP or provider. They kind of think it's normal and they take some antacids. So he hasn't been on PPI trial for his reflux symptoms. But I think these are all great questions in terms of really teasing out the history. It's not always very straightforward. And I will say for bariatric patients, sometimes I always try to tell them, whatever you tell me is only going to help me kind of figure out, what surgery might be best for you. Because sometimes I think patients sometimes minimize symptoms, thinking that, we're going to say they can't have bariatric surgery. So, but I guess my first question to the group is, I've told you about this patient. If you saw this patient in clinic, what test would you, recommend as the initial workup or eval?
I didn't ask you, Anne, is he coming to us with a primary concern for reflux disease, or is he coming to us with a primary concern of obesity and reflux happens to be one of his symptoms? Because that changes how you frame your workup and your discussion with the patient.
Yeah, so he comes with the primary I guess intent of obesity, and I think reflux is on the table, but he really wants to lose weight. That's what his reason, like, chief complaint reason for clinic visit. I guess, can I ask you, Lena, like, depending on which scenario that is, how can I ask, like, how does it change your like approach?
Yeah, so if their primary concern is obesity, then we're going to frame our strategies for management around the obesity as well. So I'm really going to focus on the weight loss. We're going to talk about lifestyle changes. Not that these won't help GERD as well, but that patient, I'm going to talk to him about the reflux, considering the type 2 diabetes. It's not well controlled. His A1C's 7 or 8. This is a patient that I'm going to talk to more about a bypass versus a sleeve for two reasons. One, his type 2 diabetes, because the bypass is a better metabolic operation, and two, because of the reflux symptoms he has. And the difference would be if he came to me with the primary concern of GERD, well, then that person's looking for an anti-reflux procedure, in which case we're going to frame the discussion around working up the reflux and then saying that, you know what, we can work on ways to get your BMI down to 35 so that then we could look at some sort of anti-reflux procedure, or we could address both your obesity and your GERD and go straight to a bypass. So that's how my discussion would be a little bit different, and therefore my testing would be different as well.
Yeah, I completely agree with Lena on that. I think that if their primary interest is reflux, then you're still going to talk about weight loss, like gastric bypass, for example, as a potential procedure for reflux. But anti-reflux procedures are also on the table, and they tend to be better, actually. So gastric bypass will normalize a pH study 75% of the time, but only 75%. Whereas a fund application is going to do it well over 90% of the time. And so a fundoplication is still a better anti-reflux operation. But people don't lose weight with a fundoplication, or if they do, they lose just a little bit and it's temporary. Whereas with a bypass, they're going to have added benefits of better diabetes control, hypertension, hyperlipidemia control, as well as the weight loss. So I think that is an important question. And if the patient's coming in for primarily obesity, then I think we're going to try to choose an operation that won't make his reflux worse. And if anything, maybe it'll make it better. And bypass, again, is one of them. But you could also consider, for example, endoscopic sleeve.
Yeah, I guess can I ask you, like, if their primary intent is GERD, and you do get them to a weight where you're doing fundification, in these patients that they start with a BMI of 38, do you worry about kind of that weight coming back after fundification, after you get them down to there, you get them have the surgery? Like, do you worry about that?
Yes.
Yeah, I would say it's a little controversial. So there was, I would argue, a lot of dogma around whether or not we should be doing anti-reflux surgery, such as a hiatal hernia repair and fundoplication on a morbidly obese patient, meaning a patient with a BMI over 35. And I think that I would have answered that question 15 years ago different than I do now, because I think we have a little bit more data now. 15 years ago, I would have said to this patient, you can't have anti-reflux surgery until you've lost weight, until your body mass index is under 35. You could consider a gastric bypass, but if you're not interested in a gastric bypass, I'm not going to do an anti-reflux procedure until you come back with a body mass index that's lower. Data has now come out to show that actually patients who are morbidly obese don't necessarily have worse outcomes with an anti-reflux procedure. So I'm willing now to do an anti-reflux procedure on a patient who's morbidly obese. Now, I don't think we know the answer yet, but I'm sure that there's a limit, maybe a body mass index of 45 or 50, where maybe the benefits are not as great for just an anti-reflux procedure alone. But I would say with a body mass index of 38 nowadays, I would be willing to do it. I know that there are people, maybe Lena is one of them, but there are people out there that still wouldn't do it. And I think that's okay. But I would just argue that there is data coming out showing that it's okay to do it in patients with a morbid obesity.
So I have a question. If you're thinking about this as a primary approach for weight control, and they have reflux, the assessment of the crural anatomy, I think, is very important in making that decision. And also, if they become a PPI responder, would you then do that as the bridge on the reflux end of things while they're engaging in weight loss by way of a procedure? In other words, do you need to do a fundoplication to treat the reflux when we don't quite yet know whether or not they're a full-on PPI responder or a PCAB, for example, PCAB inhibitor?
No, you're totally right. I mean, we're skipping a little bit. I mean, we would absolutely try medical management first. I mean, if the patient is coming to us primarily for anti-reflux or for GERD treatment, there's no question. If he's only taking, every other day, antacids, never tried a PPI, we absolutely would try that first. No question about it. I guess we're kind of jumping ahead. If the patient failing medical management, what would we do?
Yeah, and also it's framed around the patient pursuing bariatric surgery. So, so that patient, like I do pre-op endoscopy on everybody so that, we know what we're dealing with. If there's a hiatal hernia to fix, we'll fix it. And of course, if we're doing a weight loss operation, there's no fundus to plicate with. So doing anything with the LES at that time is, at least with patient's native tissues off the table, right?
How often would you do a crural repair without a fundoplication and a weight loss procedure?
If, so there's a lot of controversy surrounding that, but if the patient has a significant hiatal opening, we'll fix it at the time of the weight loss surgery. I would say most people would do that every time.
Without a fundoplication?
Yes, because as a part of the bypass or the sleeve, you're separating the fundus, right, from at the
Right.
end. Yeah.
Yeah, so I think, Anthony, the accrual repair is probably the most important element of an anti-reflux procedure. Okay.
Right.
Mhm.
Now, I am beginning to really believe strongly that the fundoplication is also necessary because we're in a study that's looking at accrual repair only versus accrual repair and fundoplication in patients that have a normal distensible valve. And I will say that patients can still have reflux if you don't do the fundoplication. But the accrual repairs where if you look at the endoflip data intraoperatively during anti-reflux surgery, where you see the biggest change in distensibility of the LES is with the accrual repair. So the accrual repair is most important. So most surgeons I would actually argue not only should we be doing not only do some of us do accrual repair, we should be doing accrual repair if somebody,
Absolutely.
if somebody has a hiatal hernia either longitudinally or has a widened crura, that should be repaired, especially if you're doing a sleeve gastrectomy, or else you're asking for trouble later. But even in a bypass, I would do it because, as we mentioned before, people with bypass do still get reflux. Now, I would also add is, what Lena said, and she and I agree with a lot of these things. I would say that if the patient is primarily here for obesity surgery, and in the case of this patient who has probably needs really good metabolic control and has what looks like reflux, and they're coming for weight loss surgery, I would only do a preoperative endoscopy. And then I would recommend I would recommend a gastric bypass in this patient. If there was some reason that they couldn't have a gastric bypass, maybe they have, you didn't mention in the history, but if they're on NSAIDs regularly and there might be a higher risk for marginal ulceration or something like that, and we need to consider, not a gastric bypass, then we might have to, move more towards some pH testing to see if he truly has reflux or not. If the patient was here primarily for reflux, different story. I mean, if they fail, we're going to try medical management first, as Anthony pointed out. And if the medical management fails, then we're going to absolutely get pH testing and objective data before we would do any anti-reflux procedure.
And so I've got to ask, EndoFlip, do you both use this in deciding on what you're going to do?
I mean, I will tell you, I just don't have access to it. When it first came out, I was able to get a machine and I was using it early on. But then when Medtronic took it over, then our system didn't buy a machine, and so I don't have a working machine. So I am not using it. We got it at one of our hospitals, but it's not one of the hospitals that I work at. So I wish I had it, and I'm putting it into the next budget, but budgets have been tight for the last 5 years. Every year they're like, no, 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 no.
Do you feel it could affect your algorithm?
Well, I will tell you that the work that, frankly, Mike's done a ton of work in this. And so I'm just giving my brief answer first, because then Mike has a lot more to share on this
I want to hear
topic,
it.
but he, is one of the world's experts in this space. And particularly when it comes to anti-reflux surgery, I would say that he is the expert, and really setting new, kind of new benchmarks for adequate surgery, gauging our surgery. And so, I think with a lot of the work that Mike's done, we're frankly moving to a place where, if you're not calibrating your surgery with this device, then you may not be doing the optimal thing for the patient. So, but this is coming from somebody who's not using it regularly, because I just don't have access to it. So I'm trying to make the argument to do so. But now I'll turn it over to Mike, because he has a lot more to say on this.
Well, yeah, I mean, I don't think for this case it's is as important. I mean, I maybe I'm not clear on your question, Anthony, but like using EndoFlip to decide on what bariatric procedure, no, we don't use it for that. Even in the operating room, we don't necessarily use it to decide what kind of fundoplication do anymore. We did look at that in the past, but I think it's really most useful for just making sure, in very simple terms, that when we close the crura and when we do our fundoplication, that we're not making it too loose or too tight. So I think
Right.
the benefit of EndoFlip is that it's telling us when we're in the sweet spot of GERD is controlled without gas bloat and dysphagia.
Right. I was thinking of it more as a predictor to postoperative GERD.
Yeah, it's not,
Not there yet.
yeah, we're actually we have a grant. We've been doing that study for the last couple years. I would just say, we haven't published anything yet, but EndoFlip is very terrible at diagnosing GERD. It's not good at diagnosing
Not
GERD.
it. Yeah.
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 I think if
I
the
didn't mean as a diagnostic for GERD. I meant as a predictor of postoperative reflux.
yeah, for sleeve. Yeah, that's what we're doing right now, and we're not seeing that it is really a good predictor
Yeah.
for
But there've
that.
been a couple of studies is why I asked. So, okay. Yeah,
Yeah, I think that there's some. I think Barham might be doing the same study as we are, or a Mayo Clinic. I don't know who's doing it now, but in any case, we are looking at that. But I could just say preliminarily, it's not really great at predicting GERD after a sleeve either.
right. Okay.
Yeah, our group actually recently got something accepted, published on this, but we looked at sleeve and bypass and obesity patients before and after with lip and who had GERD and didn't have GERD, and there's really not differences. So it's not a great predictor from at least our data that we saw. So, but good for other things. I think GERD is maybe not the best use of EndoFlip so far, but I guess in the interest of time, I'm going to move on to, I think this question, I think we sort of touched upon, does your initial evaluation differ by the type of surgery being considered? If a patient comes in like this patient, if he comes in and he's like, I really want a sleeve, does that change what you do testing wise, or you would do the same thing given his symptoms?
Yeah, so given the patient's symptoms, no, I would just do a pre-op endoscopy. I will tell you where I will do a manometry in these patients is if a patient tells me they absolutely live on PPIs, they're taking Tums all the time, their primary symptoms regurgitation, and they're insistent on having a sleeve. Because those patients, if they have a hypotensive LES and the sleeve is a high pressure system, then it's always going to overcome the pressure of the LES and cause it to relax. So, in those patients, if they have a low LES pressure, I use it as kind of an additional thing to say, you know what, the sleeve's really not going to be good for your GERD. It's going to possibly make it worse. And, in the LES dysfunction part, right? And so and that's the one place where I might get a manometry, but for this particular patient, the scenario you've presented, the only thing I do is an endoscopy.
Yeah, I think again, I tend to practice shared decision making, so I kind of present the different options. And I think in this patient, I probably wouldn't recommend a duodenal switch like you have on the end, though I think it's a good operation. I think generally I reserve that for patients with a little higher BMI than 38. I think it would really come down to 3 operations, and you have 2 of them on here, and you don't have the other. I think Roux-en-Y gastric bypass is obviously up there as maybe the first or second choice in this patient because it's going to treat the reflux as well as his weight and diabetes and other comorbid conditions. I think a sleeve gastrectomy is an excellent weight loss operation, but we know that it can either cause de novo GERD or make GERD that exists already worse. And I think I would probably, and that's why I would want to ask that question up front. Like if you've ever lost weight, does your GERD go away? Because I may be more willing to do a sleeve gastrectomy in a patient who says yes to that question than someone who says, I've had GERD no matter whether my weight is high or low. Now, in this case, he hasn't really ever lost weight, so we don't know the answer. So I'd be a little hesitant to do the sleeve. And I would tell him that the sleeve is likely to make his GERD symptoms worse or potentially can. Now, the one operation you don't have on here is the endoscopic sleeve, which we know through the MERIT trial did actually result in subjective improvement in GERD HRQL scores, afterwards. So patients lost a decent amount of weight and their GERD actually got better. It didn't get worse. So it seems to be a little bit different than the sleeve gastrectomy in that we didn't see worsening GERD after endoscopic sleeve. And I think it wouldn't be an unreasonable procedure in this patient who's got a BMI of 38 as well. Now, obviously, there's issues with insurance coverage, and if it's not covered, can he pay out of pocket and that sort of thing. But honestly, depending on what operation we're leaning towards is going to determine what pre-op testing they get. So everyone's going to get, let me just say that an endoscopic sleeve, I'm not going to even do anything. I'm just going to go in and I'm going to do an endoscopy at the beginning, and I'm going to warn them that if I find anything, that there might be a slight chance that we would postpone the procedure if we found a big hiatal hernia, for example, or something like that. If he's demanding to get a sleeve gastrectomy and I can't kind of convince them that maybe a Roux-en-Y is better or an ESG is better, then I would actually do pH testing to see how bad the reflux is. And I would, I could use that to maybe try to convince the patient, like, look, your acid exposure time is terrible, all 4 days. And I really think you're only going to get worse and be miserable. And I really think you should consider a different operation. But if they're getting a gastric bypass anyway, I don't need a pH study because it's not going to change my management. If the pH study is negative, we're still doing the bypass because we want to lose weight and fix the diabetes or improve it. But if the pH study is very positive, we're still going to do the gastric bypass. So I wouldn't get I'm not going to get a test that's not going to change my management. The sleeve gastrectomy is the one where a pH test may change it, and that's why I would get it there.
Yeah, and I think that, for this particular patient, again, antacids every other day, honestly doesn't sound like GERD that's that bad. And it's just some heartburn and no regurgitation. So I would even tell that patient, I mean, if they said, I really want to sleeve, the patient that you've put together here, I would say, you know what? I'm going to have, as Mike says, anything in obesity care is shared decision-making, right? Because it's a personal decision on the patient's part, and we want to help them get to their goals and how they want to take the journey. We share the data. And I would let them know that, we don't know how much your obesity is contributing to your reflux. So, a sleeve would be okay. And if your reflux gets worse, we always have the bypass as a backup, but if their symptoms were worse or regurgitation was one of his symptoms, I might work on some medical control and, as Mike said, do pH testing and get a better sense of how bad that reflux is.
Yeah, no, that makes sense. I think a lot of times, everything we do, I think the patient definitely has input in and how what's important to them and what would they like long term. I guess going to the other end of the spectrum, I think Mike mentioned, for endoscopic sleeve, he wouldn't do any pre-op testing. I guess in the setting of surgical options, is there anyone that you feel like doesn't need any testing, or you would recommend at least an upper endoscopy in everyone?
Yeah, I do an upper endoscopy in everybody because I want to know what their anatomy looks like. There's really nothing in surgery where I intervene on an organ I've never evaluated before. So I would at least do an endoscopy.
Yeah, studies have shown that endoscopy will change your management 20% of the time. And changing management doesn't necessarily mean it's going to change the operation you're going to do. But for example, we find H. pylori in 10% of patients, and that does decrease marginal ulceration risk if we fix that. As a matter of fact, insurance companies now, at least in Illinois, actually won't approve a gastric bypass without a preoperative endoscopy or sleeve. Without a preoperative endoscopy. So, we've been doing it anyway for the reasons that I just mentioned, that we do find things 20% of the time that change our management. But now the insurance companies even are requiring it. So everybody has to get an upper endoscopy, except for ESG, because you're doing an endoscopy, at the time. So that's the only one that doesn't need it.
Mike, I have a question in terms of ESG versus a sleeve gastrectomy. Is there anything about the anatomy seen endoscopically that would sway you one way or the other?
between ESG and lap sleeve, you know, I mean, other than, I mean, first of all, hiatal hernia, you know, as long as the hiatal hernia is not, you know, greater than 4 centimeters, which is what our cutoff was in the Merit trial. And I think I still follow those, you know, kind of rules, if you will. You know, you can do an ESG and not worry too much that there's going to be, you know, bad reflux or problems after. I would say doing a sleeve gastrectomy in somebody with a 2 or 3 centimeter hiatal hernia and not fixing it would probably be a mistake, because that patient's going to have bad reflux. So I'm not sure exactly what you mean. I mean, preoperatively, if you do an endoscopy, I don't know if there's anything that would, you know, change that. I mean, I would say perhaps a patient that has, you know, dozens of, you know, maybe hyperplastic or adenomatous polyps, precancerous polyps. I think a sleeve gastrectomy would be a better operation, because you're going to remove some of those polyps and you can still survey the others. I think if you had precancerous polyps and you did an endoscopic sleeve and some of those polyps were in the area that you're kind of making not visible, I think that would be a mistake. So I would say polyps are one in which, if I was planning on doing an ESG and I got in there, patient had never had an endoscopy before and they had a bunch of polyps like that, and they weren't just fundus gland polyps, I wouldn't do the endoscopic sleeve, but a sleeve gastrectomy I may still do. So I hope that answers the question.
Thank you.
I think you guys answered my last question somewhat, I think, in the discussion. We do have some questions from the audience. So the first question is, for me, I guess, what is this patient's RSI score and GERD HRQL? So their RSI score is 25, and their GERD HRQL score is 37. What I'm looking up. I guess I want to ask the panel, do you guys use these scores in your consideration of kind of whether you would get pH testing or not, or do you mainly base it on the patient's symptoms, type of symptoms, PPI use?
Yeah, I mean, I'm sure Lena will agree with this, but, you know, subjective symptoms of reflux are very poor predictors of actual GERD. So, I mean, I think it's not just Lena. I think all of us would agree with that. So, I mean, those are pretty high scores, by the way. You know, GERD, HR. I mean, those sound a little surprising, you know, given that he's not even really taking antacids on a regular basis, or he isn't even using PPIs. But anyway, I would say that we rarely use those scores to make decisions. I mean, sometimes we'll use those scores to make decisions on, you know, more research studies and stuff like that. But in terms of clinically, I don't know if I would depend on those you know, as much as I would actually objective data like pH testing.
Right. And I think that it's important to get the patient reported outcome, right? Because at the end of the day, what's most important is how the patient feels. And so, you know, there have been many studies done, you know, looking at different anti-reflux procedures, for example, where the GERD HRQLs normalize, the numbers drop pretty significantly. But if you look at the actual pH studies, there's not necessarily normalization, right? So, you know, is the goal of anti-reflux surgery, and again, this is going completely off topic from this case, but, you know, is the goal to improve patient symptoms, or is the goal to normalize pH studies? So I think I get the GERD HRQLs in all my patients at every visit, just so I know kind of where their GERD is. It also allows me to talk about, you know, what they can do to improve the symptoms from a lifestyle standpoint, for example, and trigger further workup if we need to. But I'm not going to make a decision, as Mike said, just based on that, because symptoms don't always correlate with the presence of acid. So it's really important. And so it depends on where you are in the treatment spectrum of the patient and what goal you're trying to reach, right? You know, just like Mike said, you don't want to do a test unless it's going to change your management. And, you know, it's important to understand what you're trying to treat. Is it obesity? Is it GERD? Is it both? You know, as you're going through the workup and the management of the patient.
Yeah, those are all good points. I think in the interest of time, we can certainly save these questions from the audience and respond back. But I'm going to move on to the next case here. So case number 2, we have a 65-year-old female here in your bariatric clinic. She had a sleeve gastrectomy in 2017, which did lead to weight loss. However, the past 2 or 3 years, she's gained weight back. Her BMI is currently 40. She also reports some acid regurgitation for the past 10 years. She had these symptoms before her sleeve as well, but they've been worsening recently where she currently has daily symptoms. It does wake her up at night a couple times a week. She has hypertension, hyperlipidemia, Maslowed. She had the sleeve with hiatal hernia repair in 2017. She takes omeprazole, 40 milligrams at bedtime. She says it does help with her symptoms. She also takes Maalox as needed. And her only prior endoscopy was in 2016 before her EGD, which showed LAB esophagitis, as well as a 3-centimeter sliding hiatal hernia. So I guess first question is, this patient had a sleeve, seemed to have lost weight for afterwards, but then has gained some of it back. Now comes to bariatric clinic interested in a bariatric procedure or weight loss options, but also has pretty significant reflux symptoms. It's same kind of question. I guess, first of all, is there anything else you'd like to know from the history, but also in this patient, what tests would you consider in the initial workup?
I think it would be great to hear Anthony start, just because if somebody's had, even if they've had sleeve, if GERD is the primary symptom, they might get to the gastroenterologist before they get to the surgeon.
Well, I don't know if Anthony is frozen, maybe.
Yeah,
I
he must
think
be frozen.
Anthony
Okay,
might
Mike.
be frozen.
Okay, well then, Mike, you want to start?
Yeah, well, I think that this is kind of a similar situation. I mean, you don't have many options here. So I will say that if the patient just came in with reflux and weight wasn't an issue, I think you have some options, like for example, a Lynx potentially, and that would require then a workup. Like in that case, I would get pH testing and you have to get manometry. And if the manometry showed, pretty much normal peristalsis or at least very minimal, weakness or weak swallows, then, Lynx is an option. But when a patient is coming in and they want, I want weight, I wanted to fix my weight regain. And by the way, I also have reflux. Then I think you're starting to think about conversion to a bypass, in which case I'm not sure I need any of the pH testing or manometry, because again, we're kind of, we're doing this for weight loss, and also this is likely to help with their reflux. There are endoscopic revisional operations if reflux is not the big deal. So if it's really the weight regain after, after a sleeve gastrectomy, and reflux is just kind of, my reflux wasn't bad, but as I've gained weight, my reflux is starting to come back, then I think you can start to think about endoscopic, revisional surgery like suturing, for example, is one option. So that's kind of where I'm thinking. So I think some of the history will be focused on, your reflux has worsened, but is it worsened with your weight gain? What is your main objective here? Is it to get your weight back down, or is it to fix your reflux, or is it both? And then I think that's going to guide me towards which procedures we're starting to think are options. And then depending on the procedure, then what testing needs to be done.
And I think just to add to that, I mean, I think Mike's spot on. I mean, patient in this situation, weight regain after a sleeve, and now having worsening reflux. To me, that's the first thing that I'm going to rule out for this person, is what I've kind of coined CFS, or crappy food syndrome. And, you know, I'm going to do a really strict dietary history with them and really work on them with lifestyle changes. Do some, you know, and kind of evaluate their sleeve at the same time. Look to see if any, you know, if it's dilated at all, if a revision might be possible. I do an esophagram and a scope. And then I bring them back, and I would say 50% of these patients tell me their reflux is gone because they cleaned up their diet. So that's a good way to fix the reflux pretty quick. And then it doesn't matter what you saw in the studies because you fix their reflux. And then you get to the question of, okay, what about the weight? And then we talk more about that and revisional options. So like, again, I think it's, you know, important to understand where the patient's coming from, what their goals are, and what they're concerned about. I mean, I saw a patient just like this today, actually, although she wasn't gaining weight, but she started at a BMI of 60, is now at a BMI of 40, and complaining of terrible reflux as she's even vomiting blood, and just recently moved to Ohio from out of state. I scoped her today, and half of her sleeve is up in her chest. And so that probably explains some of her reflux, you know. But she's lost 100 pounds. And so that's a patient that we're going to fix her hiatal hernia and convert her to a bypass. So we don't need to do much other testing.
Yeah, I would add that in these patients, I often find myself doing an endoscopy, and it's not infrequent that you do see some altered anatomy. Also, I'm using more of the potassium competitive acid blockers, which I find to be more potent and successful compared to the standard PPI.
Well, they don't require acid to work,
Right.
so they're much better in these post-bariatric patients, especially bypass where there's minimal acid-producing cells, but there still are some. But you know, they're really ideal in those situations. We've seen similar results.
Yeah.
Yeah, I think PCABs have been in some ways a game changer for, you know, treating refractory reflux, but also potentially avoiding, you know, further surgeries in patients that might be high risk or have complications. So, Lena, I know you mentioned getting an upper GI and a EGD to start. So this is their upper GI and an EGD. You can see the upper GI on the left with and correlates with the EGD on the right. So this patient has a 4 centimeter hiatal hernia, but also their sleeve. You can see I was able to retroflex in their sleeve, but also if you look at the two bottom pictures, especially the one on the left, their proximal sleeve is bigger than their distal portion. And I think this brings up the point that, you know, I think you guys touched on this, and that not all sleeves come in a lot of shapes and sizes. I guess one of the questions I had for y'all is how do we, I guess, Lena, you mentioned you get an upper GI, but, you know, how do we, from a surgical perspective, are there surgical techniques that kind of allow you to minimize GERD, or things that y'all do that maybe puts patients at increased risk of GERD in terms of surgical methods?
I mean, that's also like another hour lecture of its own, but you know, I would say that there have been many papers trying to figure this out. And when we're talking about unaltered gastric anatomy, and we're talking about reflux, we're talking about the LES, and we're talking about the hiatus. And that's pretty much it, right? We're talking about LES dysfunction, we're talking about the hiatus. When we're talking about altered gastric anatomy, like we have with the sleeve, and you read those papers, there's like 10 other reasons that people can attribute to possibly contributing to the reflux. And 99% of those have to do with sleeve morphology, whether it be a dilated fundus, whether it be a stricture at the incisura, a twist in the sleeve, all these different things. And so, you know, in surgery, I think that all of us aim to make the perfect sleeve. And I think when I first started doing sleeves, when any of us started doing them back in 2008, 2009 timeframe, you know, we didn't understand a lot of these things and the aspects of making a perfect sleeve, but we have learned over time that bougie size is important. For example, if you make it too small, that's no good for weight loss or reflux. If you make it too big, that's not good for weight loss or reflux. So you want to make it just right. I personally use a 36 French bougie. You don't want to be too close to the pylorus. That doesn't work out well. You want to be 5 to 6 centimeters back. You don't want to be right at the angle of His. You want to be 1 or 2 instrument diameters away. And you don't want to be too close to the incisura. You don't want to have too tight of a turn there. So, you know, I think that I know I'm a lot more diligent, and I think I make a better sleeve today than I did 10 years ago, because I'm more attentive to some of these details. But then you look at the sleeve morphology, and essentially there's the upper pouch, there's the lower pouch, there's the dumbbell shape, and then the tubular sleeve. And ultimately, the best sleeve that optimizes the most weight loss and the least GERD seems to be the lower pouch, or, you know, one that looks like a stocking or a hockey stick. And so I think that's what we try to emulate now. Now we just looked at some of our data, and even though we made that, like, we do upper GIs every day after all of our sleeves for multiple reasons, but academic is one of them. And so we're able to compare their sleeve shape right after surgery to, you know, follow-up sleeve shapes. And even though you may try to make that perfect looking sleeve hockey stick to start with, the stomach stretches and does some odd things over time. So that's what we're trying to figure out now, is understand what is it that changes the shape of the sleeve over time that might help us understand this a little bit more as well.
Yeah, I don't have much to add. I agree with her 100%. I think that I will say that I will backtrack a little bit and say that I have I can't think of many instances where when that patient presents to me in clinic that I don't get an upper GI. So I think an upper GI is very important. And so you know, the other stuff I still, you know, stand by, which is you don't need pH testing in everybody. It's going to depend on what you're, you know, looking to do. But the upper GI is very important, because I do think that the upper GI kind of helps you maybe go in one direction or the other. That image does look like probably the sleeve was performed a little bit too close to the incisura. Where you get that dumbbell shape is usually because the incisura is too tight, and what that does is dilate the proximal stomach. You know, we tend to, as Lena said, we tend to stay away from the pylorus and kind of preserve most of the antrum. And so we're either 4 to 6 centimeters away from the pylorus. So you oftentimes see that kind of being a little bit, you know, I wouldn't say dilated, but that part is never very tight. But if the incisura is made too tight, a lot of people believe that that can cause reflux, that can cause dilation of the proximal stomach. And so it is important to stay at least 4 centimeters away from the incisura when we do this operation. And the reason that upper GI is important in this case is that after seeing that, I might be a little bit less likely to recommend an endoscopic revision, and more likely, or you could do an endoscopic revision, but it might include doing some, you know, kind of a little bit more crazy stuff like stricturoplasties and stuff like that endoscopically. But I think just suturing that proximal stomach is probably not a long-term solution. So seeing that upper GI might persuade me more to lean towards recommending a bypass over even a lynx.
Yeah, I think you know, I totally agree with like upper GIs as being part of the evaluation, because a lot of times when we are scoping into like endoscopically, we're not really able to tell where the sleeve is located. Is it all the way in the chest? Is it not? I mean, sometimes you see the diaphragmatic pitch, but I think especially with bypass too, you don't always get a clear idea of where it is in the, you know, in the diaphragm, above or below the diaphragm. So,
Yeah, and Mike, would
um,
this patient also be a candidate for endoscopic management with that hiatal hernia?
Well, I mean, I think that I don't know how big that hernia was, but the valve was certainly wide open. I mean, the AFS grade is, is probably what, a 3 or 4 on there. So, I think that's why I would lean away from, endoscopic. I mean, when I brought up endoscopic revision as possibility, that was before any workup. But I think now the workup is kind of pushing us away from an endoscopic revision, I would say, because the valve is wide open. And I think an endoscopic revision is probably not going to fix a lot of the reflux. It might just help a little bit with weight loss. But I also worry that if the incisura is tight, that an endoscopic revision is not going to be a durable option. I would just worry about that.
I think you guys have answered this next question. And, we talked a little bit about sleeve anatomy and how it contributes to patient symptoms. And there's certainly different shapes, as Lena mentioned. And I guess as, when you have patients come to you, they're very been scoped, what elements of the anatomy do you think, I think it's not very standardized what we report on endoscopy, and it probably should be. Uh, but like, how should we describe this, or what would you want to know? Like, if you were sent an endoscopy, like in, something beyond patient has a sleeve.
Yeah. I just want to add that I think a lot of gastroenterologists really underutilize upper GI series. I mean, we depend on the endoscope to tell all, and I think we need to rethink that, especially when presenting these patients to you as surgeons.
Yeah, I mean, they're both important. I think, seeing it from the outside, but also from the inside, both are very helpful. And I appreciate, Ann, that you asked that question or brought that up, because I think there is so much heterogeneity in the reports that we get, and it does make a difference. I mean, sometimes it can lead to having to repeat an endoscopy. So I would say, first of all, lots of pictures. Pictures help a lot. And I think the things that we care about are, is there narrowing at the incisura? Is there a twist? So, you can typically, and I was looking for the pictures, I didn't see it very well, but typically you can see the staple line. And the staple line should be the greater curvature. It should be lateral the whole way, but does it kind of twist on itself? Because Lena brought up all the reasons why people have problems. She brought up too tight of an incisura, too, wide open of a fundus, or not enough fundus was taken. She talked about a twist. So I think we do care too, is there a twist? And then, I think your pictures look great. It did show kind of a dilated proximal stomach. And the fact that you could retroflex was the first thing I saw. I said, oh, the fact that she can even retroflex in there means that this is a dilated, proximal stomach. So if you can retroflex and take a picture of the LES like you did, that's very helpful as well.
Yeah, and I think a sleeve should have 2 retroflections, actually. One in the antrum, looking up at the incisura. So it should look wide open at the incisura. And I like a picture of the incisura on the antegrade view, so that you can see whether you can see through that incisura into the distal stomach, or is it taking like a tight turn? Sometimes that's helpful in the descriptor if you can't get a good picture of it. But then a retroflexion distal to the incisura, I think, is one of the things that we should make standard for an endoscopy after a sleeve. Because if the scope hugs if the sleeve hugs the scope at the incisura, it's too tight. It should be wide open around the scope for it to be an okay incisura, to emphasize the point Mike made earlier about the tight incisura.
I just want to say one thing too, that, this is one of the things that I really appreciate about AFS, is that there are many opportunities where we have GIs and surgeons together, having this conversation. And so these are the opportunities we have to actually, have these discussions about, how can the endoscopy and the reports actually help the surgeons. I just think that that's one of the wonderful things about AFS. So I appreciate you asking that question.
Yeah, I
Yeah,
agree
no,
wholeheartedly, Mike, and maybe that's an opportunity for all of us on this call and people who are tuning in, for us to create, kind of standardized reports for, bariatric anatomy,
I think that's a
Great.
huge area for, you know, for gut and AFS to look into. And certainly to Mike's point about the twist, I will say something that I notice is that when I go in with the scope, I try not to put in too much air at the beginning because that's where you're really going to see the twist sometimes. Because after a while, it just all blows up and that twist goes away real quick. So it's just to, highlight something about the twist is that sometimes it's really hard to see. And sometimes I'm just going in there right at the beginning, looking before you blow in too much air. That's usually where you're going to see it the best. But yeah, no, anatomy is, I think, a huge part of, sleep and I think patient symptoms. So just wanted to highlight that. And then, I think this is a scenario. My last question for this case is definitely a scenario that I think everyone has probably encountered. This patient, let's say we've seen the hernia, it's 4 centimeters, they have reflux, and they just want to fix the hernia instead of, hernia slash bypass. How do you have that conversation? Does it change for you if they have a normal BMI versus, a BMI above 35?
I kind of put together an algorithm. So if their BMI is above 35, or if they have abnormal sleep morphology, those patients get converted to a bypass. But if their BMI is under 35 and they have good sleep morphology, the hockey stick, that opens up a lot of other options for the patient. Could be hiatal hernia repair, MSA, RF ablation, or a combination thereof, like hiatal hernia repair with magnetic sphincter augmentation, for example. And then I use, those patients also want to do pH testing. I wouldn't put a links in without doing pH testing and a manometry. And I wouldn't also put a links in without good esophageal function. Same thing you would use for non-altered gastric anatomy, but that opens up these other options to you, and emphasizing again that the hiatus is one of the most important aspects of the anti-reflux mechanism. And so, for some patients, a hiatal hernia repair alone works really well. And at least we have, in the study we did, we've seen at least 5-year durability with hiatal hernia repair alone in GERD qual scores reducing, and at long-term follow-up, but not always normalization of pH. And so I think that's where the GERD qual can be helpful. At least our patients feel better, even though the pH isn't necessarily normalized. And as long as that acid's not causing a complication of the reflux, like a stricture or severe esophagitis or something that can't be controlled with a PPI, normalization of the pH isn't as important in that situation as helping the patient's symptoms.
That was going to be my question. How important is normalization after an anti-reflux something, whether it be crural repair alone or fundoplication with or without?
I think that's a matter of opinion, Anthony. I think there's a lot of,
I mean,
I think of it more in terms of the complications of the reflux, right? So if a person has Barrett's, if they're developing strictures, and I haven't normalized their pH, I haven't really helped them, but if it's all mostly symptom related and we've controlled their symptoms, but their pH still isn't normalized, but they don't have a complication, then maybe the normalization isn't that important.
Yeah, I totally agree with everything Lena just said to both questions. If it's okay, I wanted to add, I know we only have like a minute or two left, but I wanted to ask Lena a question that came up somebody put in a question that I think is a really good one. And that is, Lena, what do you do in a patient who's had a gastric bypass and who develops GERD objectively? And pH is abnormal. They have GERD symptoms and they've had a gastric bypass. And I'm going to give you two scenarios. One is completely other normal anatomy. gastric pouch looks good, no hiatal hernia. And the other one would be, there's the gastric pouch is up in the chest. So what would you do in those situations?
Yeah, so if they have proven GERD, I also get a manometry, and if they have a hiatal hernia, I'm going to fix it. And a normal pressure LES, I may or may not augment, but if they have proven reflux based upon pH studies, then I'm going to augment that LES with a magnetic sphincter augmentation as well.
What if
And I've done that in a lot of patients.
What if manometry is abnormal? What if they have ineffective motility, or they have 40% normal peristalsis? So let's say LINX is not an option.
Then I'm just going to fix the hiatal hernia.
What about the patient that doesn't have a hiatal hernia but does have objective reflux with ineffective motility?
Yeah, so those people, then you got to figure out that acid production, right? And this is where the PCABs might be helpful. This is where you got to really assess that pouch and make sure it's not too long or too large, that it still has a lot of parietal cells in there. That's one of the first things I think about in that situation. Or is there a fistula to the remnant stomach that I didn't pick up on before, and I need to find that fistula? So those are the different things that I'm thinking about in that scenario.
Yeah, I totally agree with all of it. Our partner, Mason Hedberg, is doing a experimental project where he's actually ablating just with APC. He's ablating basically the mucosa of the pouch with the presumption that there are parietal cells there in that pouch, and that you can ablate. He's only done a handful of patients so far, but he's actually seen some pretty good results. So whether or not that's, obviously this is not a finished project that's peer reviewed yet, but that you are kind of stuck when you've got it. You don't have anything to fix. There's no hiatal hernia. You can't put on a LINX because by the way, morbidly obese patients have a higher rate of dysmotility of their esophagus than normal, normal BMI patients. So it's not uncommon, unfortunately, to get a manometry that's abnormal that would prevent you from putting safely a LINX on, and then you are kind of stuck. So I think if the PCABs aren't working, we don't have many options. So that was a good question.
Yeah, I think that is basically our next case. But I guess I wanted to ask you, Mike, with the ablation, is he ablating normal size pouches or only bigger pouches? Just curious.
Oh, normal. I mean, it doesn't really have anything to do with the pouch size. It's just more that people vary in the number of parietal cells they have proximally, right? And so the presumption in somebody like this who's had a gastric bypass with good anatomy, but is still refluxing, just means that their LES is not functioning well and they've got parietal cells secreting acid. So the idea would be if you can ablate that mucosa and maybe decrease the number of parietal cells, then that would do it. But I don't know. That's his theory. We'll see if it works or not. Anecdotally, he's had some good results, but it's a little early yet.
Cool.
Any thoughts about non-ablative ablation with strata in this scenario?
I think Lena brought that up as a potential option that when she talked about RFA. So I think that absolutely is an option.
Well, this, I think we touched upon our last case really was, the bypass patient with reflux. I guess the question that, last question, I guess, for the group is, if you were to obtain objective reflux testing in these bypass patients, like what do you guys typically do? Do you do Bravo? Do you do pH testing? Just knowing that, with a pouch, they may have more weekly acidic episodes.
I still start with a Bravo. If the Bravo is negative, I don't stop there though. Then I do get impedance testing.
Agreed. Do the same.
Same.
Right, that's unanimous. And I think these questions, are similar to our sleeve questions about evaluating the anatomy. The size of the pouch, how long the blind limb is, how short the roux limb is. I think those are all kind of things that we should think about maybe when we do endoscopy. But I guess in interest of time, thank you to the panel for this lively discussion. I think we could all talk about this for a lot longer than an hour. I hope to see everybody in my part of town in Dallas at the annual meeting in September.
Great job, Anne. You picked cases that are absolutely very common, so and challenging. So those are great.
It's just a classic day in clinic. So,
Exactly. Thanks so much, Anne. Great job.
Thank you, Anne.
yeah, thank you guys.
Everybody.